This is a microscopic view of human internal fluids losing velocity. As the liquid slows, it becomes murky and viscous, precipitating into rigid, jagged structures. This is the formation of a calculus. Whether it occurs in the urinary tract or the biliary system, a stone represents a stasis-driven transformation of the body's liquid environment into a solid one. Western medicine maps this change through biochemistry. When fluid volume drops or mineral levels rise, substances like calcium or uric acid reach a limit of solubility, leading to crystallization. Traditional Chinese medicine describes the same physical event through an energetic framework. Here, it is understood as dampness, a pathological thickening of fluids that condenses into a solid mass when influenced by heat and qi stagnation. While the terminology differs, both paradigms identify the same three variables. When you combine stasis and high concentration over a specific duration of time, the result is a stone. By mapping these specific pain presentations to their anatomical locations, practitioners can align Western pathophysiology with TCM channel theory to build targeted treatment protocols. Understanding how these two distinct vocabularies describe the same physiological events is the first step toward an integrated diagnostic model. Healthy physiology relies on the continuous movement of fluids. When that movement stalls, temperature and concentration begin to alter the fluid's physical state. On the left, Western supersaturation. Without inhibitors, minerals precipitate. On the right, the TCM equivalent, damp heat condensation. Precipitated particles are analogous to damp accumulation, fluid losing its flow. Heat acts as the catalyst, cooking this dampness and accelerating its condensation into a solid mass. This is the physical transition from a chemical solution to a pathological stone. Microscopic aggregation eventually results in a macroscopic obstruction. Therefore, identifying the clinical signs of heat and dampness provides a diagnostic window into the state of biochemical supersaturation. This dual system logic applies directly to renal calculi. We overlay the Western urinary tract, kidneys, ureters, and bladder onto the TCM water element pathways. These stones are most commonly composed of calcium oxalate, but can also form from calcium phosphate, uric acid, or struvite. The mechanical drivers are severe dehydration, metabolic disorders, or prolonged urinary stasis. TCM classifies this as Stone-Lin syndrome, driven by an accumulation of damp heat in the lower jiao. Risk factors mirror this concentration of material: low fluid intake, hyperparathyroidism, and high oxalate diets, including nuts and spinach. The clinical presentation is unmistakable: severe colicky flank pain radiating to the groin. The pain arrives in waves as the ureter spasms around the stone. This wave-like spasm mirrors the TCM pattern of severe qi stagnation and blood stasis. The flow within the channel is physically obstructed. Contrasting this acute stasis is chronic kidney qi deficiency, which lacks energy to transform fluids, causing recurring sedimentation. The acupuncture strategy clears damp heat and promotes urination using points Ren 3, bladder 28, spleen 9, kidney 3, and liver 3. Ren 3 and bladder 28 are used to regulate the bladder, while spleen 9 is the primary point for draining dampness. Kidney 3 provides support to the underlying organ function, while liver 3 is used to move qi and relieve the pain of the ureteric spasm. Colicky flank pain serves as a physical alarm. It signals a need for protocols that move qi and drain the water pathway immediately. The logic shifts when we move to the biliary system. Here, the Western hepatic organs are mapped onto the TCM wood element. In this system, cholesterol supersaturates the bile. Without efficient gallbladder contraction, bile stasis allows cholesterol precipitation into stones. TCM labels this Dan Qi, driven by liver qi stagnation, creating an accumulation of phlegm, the energetic equivalent of thickened, turbid bile. The Western risk profile is defined by the 4 Fs: female, 40, fat, and fertile. Patients typically present with right upper quadrant pain that is triggered by fatty meals and radiates toward the right shoulder. This shift from a dull ache to a sharp post-meal distension corresponds to the TCM pattern of liver qi stagnation. Symptoms like bitter taste, nausea, or jaundice indicate progression into liver and gallbladder damp heat. The treatment strategy soothes the liver, clears damp heat, and promotes bile movement using points gallbladder 34, liver 3, Sanjiao 6, and gallbladder 24. Gallbladder 34 is the influential point of the sinews and is used to drive gallbladder function, while liver 3 moves liver qi. Sanjiao 6 regulates qi in the Shaoyang channel, and gallbladder 24 acts as a local front mu point to target the organ directly. This post-meal right-sided pain requires a pivot in strategy. You must unblock the wood pathway rather than draining the water pathway. To differentiate these pathologies, we use a 3-step framework. First, identify the location. Flank pain involves the kidney-bladder system. Right hypochondrium pain involves the gallbladder-liver system. Second, identify the pain's nature. Colicky, wave-like pain indicates acute obstruction. Distending, post-meal pain indicates stagnation. Third, identify the underlying TCM pattern. Heat signs point to damp heat. Weakness suggests deficiency. Sharp, fixed pain points to blood stasis. Side by side, we see the Western mechanisms of mineral crystallization versus cholesterol precipitation. This dictates the movement strategy, promoting urination or bile flow. The completed matrix reveals a consistent structural alignment between Western anatomical blockages and TCM channel obstructions. While the chemical makeup of these stones differs, the underlying failure of fluid metabolism is a shared feature of both conditions. Resolution across either medical paradigm requires the same mechanical result: breaking the stasis, clearing the heat,